Welcome back, everybody. We are going to move into anxiety, somatoform, and dissociative disorders. So let's start with talking about panic disorder. And panic disorder are episodes of intense fear that will trigger physical reactions, even though there's no actual danger present. And that leads us to talking about panic attacks. So panic attacks are very common in just general society, but they're also very common among first responders. And part of that is because of the constant trauma and the extreme adrenaline that first responders experience with much greater frequency and intensity than your average person. So let's talk about that for a little bit. And oftentimes, many first responders will be called to respond to panic attacks because people literally, when they're having a panic attack, think they're dying. So they tend to call 911, they call the police, they call the EMS, etc. So panic attacks are characterized by an increased heart rate. So your heart is going to be pounding, pounding, pounding. People think they're having a heart attack. Increased respiration. I can't breathe. Like I'm breathing so hard, I can't get enough oxygen in. Sweating, shaking, dizziness, and ultimately you fear that you think you're dying, right? When in fact your body is having an inappropriate adrenal response that occurs without an adequate trigger. Panic attacks can be debilitating, right? It can lead to massive life interruptions, especially for people who get them chronically. They are terrified of having another panic attack, period. But certainly people get very, very worried and scared about having them in public because they don't want to make a scene. They get worried that they won't be able to keep themselves safe. So if I'm driving down a highway and in the middle of 65-mile-an-hour traffic, I have a panic attack, well, then I'm really going to die, right? Because I won't be able to control the car. And this can result in really debilitating outcomes because then people stop doing those things. I've heard of people with chronic panic attacks that stop eating because they're afraid, eating alone because they're afraid they'll have a panic attack while they're eating and then they'll choke. And if nobody's home, nobody will be there to give them the Heimlich maneuver. So it can lead to all sorts of inhibitions in daily function. Right? I've heard of people who will never drive on the highway again because of panic attacks. I've seen people who have lost serious weight because they will not eat unless someone's home with them because they're worried about panic attacks. Agoraphobia is something that often happens in rare instances in a result to chronic panic attacks. And agoraphobia is just a really fancy terminology for people who are scared to leave their house, right? That certainly I don't want to have a panic attack in public, but you know what? Everything in public is what might trigger that panic attack in the first place. Here in my house, I'm safe, right? I'm safe, so I'm just never going to leave. These people often end up having shut-in lifestyles, right? And first responders are going to come into contact with them in terms of people calling for welfare checks. Sometimes the shut-in individual themselves will become a sort of frequent flyer and try to utilize first responders to do things they're not capable of doing outside of the house, etc. So you may encounter people with panic disorder and who get so severe that they're agoraphobic. Generalized anxiety disorder is chronic and excessive worry over events and situations in a person's life. Now, we all have anxiety from time to time. We all have stress. We all have worries, right? But this is constant. This is it's never ending, right? It's 24/7. In your waking hours, you're constantly feeling extreme anxiety about something, right? When the worrying starts, the anxiety skyrockets. This can result in irritability. It can result in serious sleep deprivation, restlessness, and just a general inability to control somebody's anxiety. We treat generalized anxiety disorder with antidepressants and anti-anxieties and cognitive behavioral therapies, where we try to get them to recognize that these anxieties, these worries, these thoughts are exaggerated. In real life they're this big, but you've made them this big. So we need to change the thought processes in order to change the behaviors. Obsessive compulsive disorder is characterized by disturbing, reoccurring images and thoughts that cause severe anxiety. And that is coupled with the belief or with certain compulsions or behaviors that if I just engage in these behaviors, these thoughts won't happen. It's a pretty wild thing if you think about it, right? So they have these persistent thoughts that they can't stop, that cause them so much worry, anxiety, discomfort. And they think, this is how I will calm the anxiety and make sure that bad thought doesn't stop, is I'm going to turn the doorknob 13 times and then walk through the door. Because if I turn it once, then this thought, which could be something like, I might die, something that, I mean, it doesn't make any sense, any logical sense, but the thoughts are ever present, and it causes massive anxiety, and they can't quell that anxiety without the compulsive behaviors. So it might be something that, makes absolutely no sense. Like, I have to walk in and out of the door 5 times before I can stay in my house at the end of the day. But literally, if they don't do that, they will feel intense, extraordinary anxiety that something bad is going to happen. This can, in extreme states, become very, very, very debilitating. There are people who will spend enormous amounts of their day engaging in compulsive behaviors to try and minimize that anxiety. It renders them unable to hold a consistent job. It renders them unable to hold relationships with significant others, family members, and friends. And it ultimately ends up in them sort of creating some isolationism in their world where they can engage in their compulsive behaviors without being judged. Okay. Strongly related to obsessive compulsive disorder, which would involve a lot of first responders, are going to be 3 other circumstances, and that's going to be kleptomania, pyromania, and pathological gambling. So kleptomania is literally it's a different form of OCD, and it's the overwhelming impulse to steal things, right? And that the individual will have extraordinary anxiety until they steal something. And often it's things of absolutely no value, right? Like, why would you steal this? Why would somebody, like you just stole a packet of pencils because you think it will help you with your anxiety? Like, why would you do that? But it's an anxiety disorder, and it is the compulsion of the taking that brings down the anxiety. Obviously, law enforcement and first responders are likely to come into contact with this because people running businesses are going to, what are you doing? Right? They're going to call the police. This is the 4th time this week you've come in here and you've stolen something random. I'm calling law enforcement in. But it's important to understand that they're not necessarily criminals, right? They're not diamond thefts. They're not robbers, right? They're literally, this is a compulsion. This isn't driven by an overwhelming sense of anxiety. So certainly that should guide your reaction and your behaviors in those exchanges. Ooh, excuse me. Pyromaniacs are exceedingly rare. They do exist, but it's not hugely common. But again, these are people who experience intense anxiety that is only relieved by setting fires and watching fires burn. Right. Again, this is an obsession compulsion circumstance, and it will not be controlled or deterred without medication. I mean, if you try to reason with them and say, like, you're destroying property, you're putting people in danger, certainly firemen are going to be the first responders who engage with this. You can talk all the logic you want, but because it is compulsive and it is driven by that anxiety, it won't stop their behavior. This is not a mind over matter situation. They need a medication. And finally, pathological gambling. Again, this is excessive gambling, which is done to quell feelings of anxiety that overwhelm a person. This can result in destroyed relationships, domestic situations, violence is ever surrounding these people as they often are in debt to the wrong kinds of people. And these are all situations where first responders may be called in. And again, there's no logic reasoning here. It literally, these are individuals that need to be medicated because they are experiencing the negative consequences and it's not stopping the behavior. This is a compulsion. I want to move on and talk about post-traumatic stress disorder. Many first responders of all kinds are suffering from this themselves or will experience post-traumatic stress disorder at some point in their career because of the exceptional amount of trauma that you're exposed to. You see a lot of carnage. You witness a lot of terrible, right? More so than your average person. And that repeated exposure can lead to PTSD, which is where people start having flashbacks of, awful traumatic circumstances that play in their mind, with the specificity of a movie reel. Feelings of helplessness, feelings of fear, the inability to sleep or to get rest, concentration impairments, social withdrawal, intense anxiety, irritability, right, reactivity, right? So all of these things can result in interfering with daily life, in relationships, in your job, in your execution of your duties, in simple things like going to the grocery store. This is a very common disorder among first responders. It's also exceedingly common among people who have served in the military. It can also occur in people who have experienced trauma, people who experience some kind of severe physical abuse or sexual violence. It's not uncommon for them to develop PTSD. There is a huge relationship between PTSD and substance abuse. People are trying to self-medicate, right, by using mind-altering substances to get themselves to sleep, to not have those flashbacks, to not feel that anxiety and that fear, to numb themselves. And certainly the marriage of those two factors, the presence of the PTSD plus the presence of the substance abuse, is, just the perfect recipe for first responders to have to be on the scene. As first responders, when you engage with somebody who has PTSD, you want to focus on de-escalation. You want to provide a supportive and a safe environment that results in calming of the circumstance. We also use medications that treat anxiety and depression. We utilize service animals that can recognize triggers that will provoke PTSD symptoms, and they will they will lead their human away from those triggers or warn them of the triggers so that they can, reconfigure what it is that they're doing. Exposure therapy has had a lot of help in cases of PTSD, and exposure therapy is when you take the focus of that upset or that fear or whatever it is, and you start exposing them in very, very small doses, and each time you expose them to a little bit more, to the point where hopefully you can get to the point where they're desensitized to it and it doesn't upset them in that capacity anymore. So you learn to manage the trauma very, one bite at a time, and each time you can bite a little bit bigger and a little bit bigger. Let's shift gears onto somatoform disorders, and these are going to be mental health conditions that cause an individual to experience physical bodily symptoms in response to their psychological distress. So we're going to start with what is called somatization disorder, and these are individuals who have complaints of physical impairment and pain, despite the fact that there is no organic evidence of diagnosis, ailment, or injury, right? There's no basis. They might say, like, I have tons and tons of pain, but there's no reason for it. There's no demonstration of it that can be identified. These individuals might experience blindness, and we can't figure out why, right? Well, ultimately, it is a psychologically driven issue. Seizures, paralysis with no etiology, right? Just out of nowhere. There's no broken spinal cord, broken vertebrae. There's no accident. There's just suddenly one day they're just paralyzed and they can't move. These are individuals who will not seem panicked by their condition, and they often obtain what we call secondary gains in the form of attention and sympathy. So those secondary gains are feeding, the mental illness. That it's a reinforcer. It's positive reinforcement. This is much more common in women than it is in men, and it's incredibly difficult to treat because there's no great incentive for this population to change because they thrive on the attention, the caregiving, etc. Next is hypochondriasis. These are individuals who believe they're suffering from a disease that has no real basis in medical diagnosis. These are often your frequent flyers with the EMT, right? They might call 911 an awful lot and have the ambulance come out, and there's nothing wrong. There's extreme anxiety that they have an ailment, that they're dying, that they're getting very sick. And no amount of reassurance from medical professionals, no amount of testing, no amount of negative tests will relieve that anxiety. It's very important to make the distinction that these are not delusions. These are not delusions. This individual truly believes that they are ill, and they will behave in ways that inhibits their daily function as a result of their perceived illnesses. Often, even when one illness is dispelled, eventually some other illness will quickly, fill in. And like I said, these could be your frequent flyers, but ultimately they are responding to overwhelming anxiety. Conversion disorder typically is something that occurs right after a traumatic event. This is when somebody manifests neurologically related symptoms, and specifically we're talking seizures, blindness, deafness, paralysis. Okay, they're going to manifest this But there's no observable etiology. There's no cause. There's no organic identifiable reason that this is happening. And ultimately what it is that their mind this is why we call it conversion disorder. Their mind is converting that trauma into some physical suffering, that literally there's just too much for their mind to manage in, response to the trauma that occurred. And it converts or, transforms into physical suffering. Um, these people are typically not worried about their conditions, which helps to distinguish them from people who are suffering from real neurological problems. Um, so it's important to make that distinction. I want you to understand a term because it's really important when we talk about somatoform disorders to distinguish between people who are experiencing symptoms that are psychologically driven versus people who are malingering. And that's the term that I want you to know. And people who are malingering are knowingly and intentionally faking symptoms of an injury. And they're doing it for some kind of primary gain. It's typically monetary gain. Right. So that they can sue somebody and win a lawsuit, or so that they can get workman's comp and get paid without having to work. Right. They are fully aware that there's nothing wrong with them. They are trying to fool everybody else. This is very distinct from other somatoform disorders, where the individual is psychologically believes that they are ill, right? And it is manifesting itself in a physical symptom. They're not faking. They're not trying to hustle somebody for cash. They're literally their disorder needs some sort of therapy and medication versus somebody who's malingering just needs to get caught, right? They need to get caught and pursued for, like insurance fraud or something. Body dysmorphia is is another circumstance that is becoming more prevalent in today's society. These are people who are preoccupied by real or imagined defects. I say that in air quotes because the rest of the world may not see it as a defect, but they see it as a huge defect. But typically the defect is something that only they can see. Really common with eating disorders with both anorexia and bulimia. This is also becoming increasingly common with plastic surgery, right? That when people start getting plastic surgery, some people just can't stop and they keep getting more and more procedures because they think it's going to make them look better. And ultimately they just look very strange. The rate of unnecessary surgeries, especially among that plastic surgery community, often results in physical complications because we're not supposed to be undergoing surgery after surgery after surgery. And therefore, this may become somebody or that, the EMS comes into contact with regularly. We're going to move on to dissociative disorders. And dissociative disorders are the alteration of memory, perceptions of reality, and sense of identity. So we're going to start with dissociative amnesia. Again, this typically follows extreme trauma, and it is seen as the body's or the brain's coping mechanism, that something really awful happened. It's more than the individual can process, so the mind just wipes it out of the memory completely. The memory essentially needs to disappear for the well-being of the individual to avoid the emotional pain and the disruption. Personal details cannot be recalled, right? But this is very, very rare. You're going to see this in movies a lot more than you're going to see it in person, but it does exist. We also have dissociative fugue. This one's a little wild, right? It's similar to amnesia, that somebody might lose all memory of themselves and then pass, or excuse me, themselves and their past. But what distinguishes them from people with amnesia is that they're just up and move. And they're like, well, I don't know who I am. I don't know where I came from. I don't know what's happened for however long I've been alive, but I guess I'll just pack my bags and start a new life somewhere. And they literally do. They may create a new identity, start a new life, marry a new spouse, even though they have one somewhere else that they forgot about. And again, this illness tends to be very rare, but also the result of a stressful or a traumatic event. Interestingly, it starts just as quickly as it ends. So it comes out of nowhere that you just forget everything about you. And one day it leaves out of nowhere and you just remember everything. So that one's kind of wild. The final one that we're going to go over is dissociative identity disorder. This is an extremely controversial diagnosis. There is a huge divide in the mental health community over whether this is even real or not. You probably know it by the more common, the sort of the pop culture name of multiple personality disorder. We used to call it that. We've changed it to dissociative identity disorder. There are many clinicians out there who believe that this is just not a thing, right? That this is a group of people malingering for attention, right? To sell books, to sell movies. But there's also a contingent of medical and psychological professionals who believe that it's absolutely real. Um, there are elements of amnesia and fugue that are coupled with what we call fragmentation of the mind, and that fragmentation creates new personalities. The I call the host personality, the main person, is unaware of the other personalities. The other personalities are there to typically manage stress and trauma that the main personality cannot manage on their own. The personalities usually know one another, but like I said, the main one doesn't know about any of them. This has typically been demonstrated after extreme forms of trauma, so extreme physical or sexual abuse. We see this related to prostitution sometimes. And the concept is that each personality manages a portion of the person's life. The treatment is therapy, and the idea there is to get them all to marry into one person again, so that rather than different personalities, it's all one personality with different coping mechanisms.